Physiologic anemia of infancy. In the womb, there is hypoxia, physiological hypoxia. So hypoxia-driven erythropoiesis takes place, and thereby you have every full-term infant has now more common in the preterm has little bit of your higher hemoglobin and RBC mass. It is a very high figure in 16-18 gram in the term infants. But when the oxygen hypoxic drive is over, your gradually your erythropoiesis declines and you have hemoglobin a little bit in the lower side. It takes place by 6 to 8 weeks of the postnatal life. This is called physiologic adaptation, anemia of infancy, and there is also another thing. The hemoglobin F is replaced by hemoglobin A by 6 to 12 months. So persistence of this fetal hemoglobin in thalassemia is another entity disease, rare things, but it is a grave disease. So during this transition, there is also less amount of fetal your oxygen transport in the infant. So they are not the problem because the physiologically they are not the problem. But the problem is that when there is concomitant nutritional anemia commonly in this country, iron deficiency anemia or other disease supervenes, like the hemolytic anemia and others. So they have little bit of severe sort of physiological exaggeration of the physiological phenomenon. This is being identified with the ferritin. Serum ferritin less than 5 microgram per dl in under 5, and above 50 less than 15 under about 5 years is diagnostic of the iron deficiency anemia. And other iron investigations like iron binding capacity, serum iron, they are also diagnostic. Both are microcytic hypochromic. Even your hemolytic anemia, it is also microcytic hypochromic. Thereby differentiation of the absolute differentiation of the hemolytic anemia along with the clinical feature, you have the electrophoresis. But hemoglobin hemoglobinopathy is severe sort major, beta thalassemia major have only hepatosplenomegaly, minor do not have hepatosplenomegaly. So thereby clinical may not be obvious in all the time. Thereby doing an electrophoresis in those rare cases may be useful. But ensuring enough food, enough balanced food, so that optimum growth takes place. Breastfeeding up to 6 months and complementary feeding thereafter. 1, 2, 3, 4, 5. After 9 to 10 months, actually child needs 5 complementary feed, all balanced. Your hemoglobin improving foods like like banana, there are arams and others. They must be ensured. And all the balanced proximal principle, balanced diet. Most of the time the children consuming balanced diet do not have concomitant iron deficiency anemia. Thereby balanced diet plus taking care of these things, and you can give little bit of iron in physiological, even the in a normal microcytic hypochromic anemia, because it is quite common, 2 to 6 micromilligram per kg per day for 3 to 6 months in your infancy.